Hello. Welcome to OB Healthy's. Actually, this is the Doctor's Lounge, all righty? And we physicians are here for two basic reasons. Number one is to improve health in those of African descent. But number two is to influence or to encourage, I should say, encourage young Black males to go into medicine because there's definitely a shortage and we want to keep that enthusiasm out there. So, as Black physicians, we want to encourage them to think about it. Think about science, think about medicine if you're going into that field. All right. Our webinar is every second Saturday of the month. And all you have to do, and as you have done already, but let others know that all they have to do is come on the OB Healthy website and click the doctors and come in because it's so important that they listen to educate from a medical perspective. But number two is also to be able to ask your medical questions because we're here to answer your questions. All righty. If you want to see our past webinars on that page, that OB Healthy page of where the doctors, you'll see a camera, or you can go to our YouTube logo and just hit that. All of our past webinars are there. All so many different, I should say, diagnosis or medical problems are talked about. So you go on and check it out. All right. Remember to subscribe to that page, that webinar page, because that way we can continue to bring it to you. I'd like to thank OB Healthy for allowing us to bring this webinar to you, the Doctor's Lounge. And the most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician, because only your doctor, truly only your doctor, can take care of you properly from a medical perspective. Okay? All right, I think we're ready. Today, I'm so excited because we have a topic that's not talked about often. It's palliative care and hospice care. And as Black people, we kind of look away from those difficult situations sometimes, but it becomes very personal because we all, no matter who you are, at some point in your life, you're going to have to deal with, a very sick relative, be it mom, be it dad, be it your sister or brother. We're going to have to deal with that. And those are difficult decisions to make. And the doctors and the nurses are going to be asking you to make those decisions. So the more you know about these subjects of palliative care and hospice care, I think the better it is, because those decisions are very, very difficult to make, and especially when it gets personal and one side of the family wants something this and another side of the family wants that. It gets very difficult to come together and decide what to do and how to move forward. So we're here for that. What I'd like to do, as I always state, the other docs will be joining as the program goes on. Dr. Court,
Okay.
introduce yourself, please.
Dr. James Court. I graduated from Howard University long time ago. I'm honored to be with this esteemed group of guys to educate us as Black people on certain subjects that Dr. Bay says very difficult sometimes to deal with. Um,
Thank you, Dr. Court. I'm Dr. Omar Bey. I'm a retired pulmonary critical care doc, and right now I'm the director of nutritional support for Newark Bethesda Medical Center and the ICU, I should state, at Newark Bethesda Medical Center. All righty. Today we have a brother with us, and he's out of Atlanta, right? Atlanta,
Yes, sir.
the Atlanta area, and his name is Dr. David Blake, and we are so happy to have him come and talk about these two topics. Dr. Blake, you know what I'd like for you to do? I'd like for you to just tell us who you are, why you went into medicine, where your practice is, what kind of patients you're seeing. Why did you want to do this profession anyway? It's a crazy profession. Why would you even want to go in this? Tell us about yourself, brother.
All right. Well, for those of you who would let me indulge a little bit and tell my corny story, I'm originally from the Bronx, New York. grew up there, relocated to Atlanta, Georgia in high school, and finished high school there. Further matriculating to Dr. Court, Howard University for my undergraduate degree. Go Bison.
Mhm. All
And
right.
graduated medical school from Morehouse School of Medicine in Atlanta, Georgia.
Mm-hmm.
The decision to become a physician goes way back, as with most people. And it truly was because there was not a lot going on in those days. You either went to school, and if you were fortunate enough to be able to get in and afford to go, or you went into the military or some other sorts of industries. And in school, the professions were teaching, doctors, lawyers, preachers. I mean, there was no internet. There really weren't any web-based engineers. So my father and mother were both teachers, and father told my brother and I he'd break our legs if we went into teaching because it was an unfortunately thankless profession. Uh, Lawyer, my brother had said he would become a lawyer. So being the younger brother, okay, I'll be a doctor. Lo and behold, finally got through high school and realizing that I concentrated so much on math and science, I figured I better give this doctor thing a go. I didn't know anything else. Thank goodness I was able to trudge on through and graduate and went into family medicine as far as my specialization goes.
Mm-hmm.
And then the family began. I have four daughters, and the drive to have to work and pay for them and repay student loans and build a home in the future led me to try to find other aspects of healthcare to work and generate income.
Mm-hmm.
And one day I stumbled upon a woman leaving the nursing home where I was actually on staff there, and just asked what she did and what the business was that she was discussing with the people at the nursing facility. And she was in hospice care. Didn't know what hospice was. And as you gentlemen might co-sign, they didn't talk about hospice and end of life and palliative care in medical school and residency
Mm-hmm.
back when I was coming through. And I'm going to assume probably the same for you gentlemen as well.
Mm-hmm.
Yes.
So
Yes.
ask her some questions about it and ask her, hey, do you need a medical director? And she said they had just hired one who happened to be a buddy of mine, but they did need somebody to help with marketing who knew the community, which thank goodness I did. And that was my introduction into hospice 24 years ago.
Mm-hmm.
So over these many years now, I've worked for four different companies and been with the most recent one for the last 16 years now. And I get to travel the United States and I'd say international. So I got to go to the NMA in Toronto many years ago. So that makes me now internationally known. But getting a chance to meet doctors like Dr. Omar Bey, whom I met last year in New York, and giving a presentation there, stumbled upon each other, and now have this opportunity and kind of sort of become an expert in end of life and hospice care. Something that is needed, that is not talked about in our community. And usually when it does come up, it's at end of life. And the family members, the caregivers, they're really distraught and distressed and trying to make these hard decisions in a time of need and urgency as opposed to preparation. So hopefully communications talks like this will start to open things up to that we will learn to look into these aspects of healthcare sooner than later so that it can be a better outcome for the patient and for the families. And just in the past 2 weeks, I received a call last week from one of my medical school classmates about a colleague of hers who is a physician, but going through this end of life walk with her father, her beloved dad, and trying to make this decision in the throes of where you are now, Dr. Bay, in the ICU, in critical care. He's intubated. What do I do? Last night, another one of my colleagues called me about a friend of his whose father is also in the hospital currently and at the VA, and what to do for him. And making these decisions is hard. And usually the caregivers in the families, that person is that oldest daughter. And now that's daddy. Daddies and daughters are different. And so now they have to make these decisions. So we'll talk a little bit more as we go along today about how we can get a jump start on this preparation for end of life, which is coming, whether we like it or not. One of my colleagues in hospice care has said, none of us getting out of here alive. So the key is to live a long, healthy, productive life and then have a good and glorious end of life with surrounded by those that love us and we love as well.
Right, right. I, excellent, excellent start. And I'm going to ask a few questions, but first I want to tell the audience, please, I know you have questions out there. All right. Don't be afraid to type in your medical questions. We're going to answer them. If possible, we're going to give the best answer we can to any and every question. No questions too small, no questions too large. Please ask your questions. All righty. Um,
Yes,
let's start off with palliative care. I mean, it's a big word. You know what I mean? It took me a moment to even say it, palliative care. But what is palliative care? I mean, and we'll get to hospice later, but you know,
sure.
just give me an understanding of what we're talking about when we're talking about palliative care.
Well, we're talking about palliative care. We're talking about treating symptoms, giving comfort.
Mhm,
And it is difficult for physicians to, if you will, admit defeat, meaning we can't cure, we can't make the disease process go away.
mhm,
And the reality is, there's not many things we can cure. One of my surgeon colleagues says, well, they can cure gallbladder disease because they can take the gallbladder out. Now it's cured. Ta-da. But in our medicine world, there are many things that we cannot cure, but we can treat the symptoms, manage them quite well.
mhm,
But there does become a time when the disease process starts to take its toll on the individual, regardless of how diligent they've been at adhering to their physician's recommendations, taking their medications, doing their follow ups, eating healthy, changing their diets, exercising. There will come that time. And at that point in the person's medical care, that's when we want to start keeping them pain free,
mhm,
try to deal with their depression issues as they're coming to grips with their mortality, deal with any anxiety and agitation. We're treating the symptoms. And we're also treating anything acutely that comes up. So keep in mind, keep saying treating, because many people think that palliative care means we're not treating the patient, we're just going to sit there and hover. But no, we're still treating. We're just not treating for cure. So we do address respiratory infections, cough, cold, flu, pneumonia. We address urinary tract infections. We address skin if there's becomes a lesion or pressure injury. So those things are taken care of. It's just that the underlying disease, we're doing the best we can at that point, but unfortunately, that disease process will take its toll over the course of time. So we're palliating the patients and the family members as well, because that also now addresses the caregivers, the survivors, the ones that are going to potentially have some remorse about how their loved ones' last days were. So we want to
mhm.
get everybody prepared for that. So
Right,
that's the
right.
palliative care.
Okay. Yeah. You know,
Question, question.
go ahead, Dr. Cord. I see your hands up.
Yeah. Question for you, doctor. Do
Yes, sir.
you write orders or you just make recommendations? Maybe at your institution, because it might vary depending on where you are.
Sure. Well, first of all, I'm in solo private practice actually, and palliative care, hospice care, that takes place at home. So it's not necessarily a place or an institution, but if the patient is in a hospital and these questions are coming up, you gentlemen are making rounds, the palliative care team can write orders and definitely makes suggestions when you do the consultation. So they'll address whatever questions that you may have had in their consult note, hopefully, and then they should also be able to communicate with the family members as they gather around to make the ultimate decisions for the patient and their care, such as do they want to have feeding tubes inserted or not? Do they want to be resuscitated or not? So those are questions that can be addressed and orders written to um, resuscitate or not, to intubate, to put in feeding tubes. Those decisions can be made during that palliative visit.
Yeah.
Okay.
Alrighty. I want to, we as Black people, a very, very important aspect, especially when difficult decisions are to be made, is our religious, um, support. How is that? Because I know a lot of times in the hospital, in the ICU, that's not touched upon. It all depends on the physician. It all depends on, whether that's something that they think about. How do you pull that in, and how can we as physicians also make sure that that's happening for the patients that we're seeing, or when the families come in, make sure that that aspect is taken care of or even thought of, that we should talk about the religious aspect of passing.
This is perfect timing, Dr. Bay. I work for Vitas Healthcare, the nation's largest provider of in-home hospice in the United States. And just last week, this past Monday, we did an event called Bridging the Gap, bridging that gap between the medical community and the spiritual community to show that that is indeed very important and goes hand in hand. So that is one deal to one recognize that there is a spirituality aspect out there for people. And now not to get into anybody's specific and unique beliefs, but just understanding that they follow somebody. So acknowledging that, advising them to call in whoever their spiritual leaders are to come and take part in that conversation. And that can be very important because in some churches, you might have heard yourselves commentary that the true doctor is the Lord, and the earthly doctors can't cure everything, and so there are still miracles. And to try to communicate with the spiritual leaders so that we're all on the same page as how we're addressing the patient and the loved ones. Not stepping on anybody's toes, not superseding anyone, but working together. Because the patients, the caregivers, they are going to go back and ask their spiritual leaders for their insight. They're going to go to their family physicians, internal medicine physicians, as they're leaving the hospital setting where maybe those doctors weren't making the rounds. So all of these people that are now being looked to as the specialists, the experts, that's where we want to work together. So welcome in whomever that patients and family members, spiritual advisors are to be part of the communication as you're talking with the families of what can and cannot be done at that time. So that way you can go ahead and support them. Of course, we have our patients who don't believe in transfusions of blood. We have our patients who may not necessarily believe in Western medicine at all. So we want to be able to communicate and get everybody educated to the same level and sole purpose of taking care of that particular person or congregant in their time of need.
Right, right. I want to bring this up because I see it sometime in a hospital that if a patient comes in and they're not 100%, with Western medicine, then sometimes the physicians themselves are a little uncomfortable as far as it's almost like you're challenging their ability or your youth. You know what I mean? It's an uncomfortable situation sometimes. I think that how do you handle that when a patient comes in and they may believe in one way of medicine, or holistic medicine, or even whatever it may be, and it's not quite Western medicine, but the patient is sick and in the hospital, dealing with those physicians and that are Western trained, and trying to get them to understand that side of the equation, that these people have real. I mean, this is real to these people. Do you find that? Have you come in contact with that? I should say.
Oh, every day in my medical practice. And, the first question might be, well, why are you here? But, we have to put that to the side because they are here. So a better way to probably look into that is, well, tell me what you know or have heard about your particular unique condition
Mhm.
and hear what they have to say. Not challenging them, but asking where they might have gotten their information from. Because now we have Dr. Google, Chat GPT, Joe the mechanic down the street. So we want to
Mhm.
hear, what did you hear? Where did you hear it? And then you can turn around and explain to them, well, this is how I was trained. This is what I have learned and researched, and maybe even quote some reputable sites of where you're getting your information from.
Mhm. Mhm.
I get challenged with high blood pressure on a daily basis. I have to let patients know about the Joint National Committee of Cardiology, the American Heart Association, the International Society of Hypertension in Blacks recommendations as to what high blood pressure is and how we should address it and treat it.
Mhm.
And then lastly, you can always, the way I was taught, and I hope that you can chime in and co-sign that, we can always treat with observation. Okay, well, fine. Let's go ahead and maybe attempt it your way, unless you see otherwise that something is going to be life threatening for them. But if there's an opportunity to let them follow their own thoughts and guidance, well, let's give that a shot. Let's see you back. Give them a
Mhm.
time frame, 2 weeks, 1 month, but just advise them to come back and communicate with you and keep that line of communication, that door open.
Yeah, yeah. I know that, and I understand. you're on top of this. I see it more so in some of the physicians that I work with in the ICU. You know, if a patient comes in and they're not 100% going with Western medicine, then the physician kind of backs off and say, okay, then we're just going to let you be. And me personally, I don't think that's right. Um,
Mhm.
but I think that from your perspective, and I hope that what you're out there doing and educating, you're educating physicians as well as families. That's what I'm where I'm going with
Oh,
that.
yes, sir. Well, again, you're a prime candidate. You saw the lecture to the internal medicine section. The previous day, I'd spoken with the family medicine section, and I've been speaking with the National Medical Association of Family Medicine section for maybe the last 10 years.
Mm-hmm.
In Georgia and Atlanta, I'm past president of the Atlanta Medical Association, the oldest African American uh, um, physician group in the United States, which led to the institution of the National Medical Association.
Mm-hmm.
Current chair, past president of the Georgia State Medical Association. And so I've had a chance to lecture to that annual conference over many years as well.
Mm-hmm.
So, yes, those are specifically reaching out to physicians. There's also a program called EPIC, which is educating physicians about end of life, that started out of in Chicago, out of Northwestern, I believe. So these are programs specifically guided to educating physicians. Because as I state in many of my presentations, that if you have a doctor who's older than probably 50 now, he or she was not educated in end of life care.
Mm-hmm.
I know my first introduction to hospice was during a surgical rotation after performing a Whipple procedure with the surgeon. And he reached over to me and said, okay, Blake, go call those hospice people. That was all I got in
Mm-hmm.
residence in medical school training.
Mm-hmm. Yeah, I agree. I was the same way here. I didn't get, and I don't know if Dr. Court did, but I didn't get very much training at all in hospice and palliative care until in the ICU and then working with them, and then gradually I understood it. Yeah, I agree. Tell me, as far as you know, the difference between, and let's just go to hospice just a little bit right now, the
Okay.
difference between palliative care and hospice. I know, I'll let you go ahead with that. Maybe you can just introduce some of the aspects of hospice and we can talk about some of the differences. Mhm.
Sure. Well, starting off, palliative care is not something that's actually billable as you go through. So
Hmm.
that's where you are, as Dr. Court was asking, kind of walking beside the treating physicians as to making suggestions, offering some treatments for palliation.
Mhm.
Now, all hospice care is palliative, but all palliative care is not hospice. Hospice is specifically the end of life, when that palliative patient makes that final turn to where you're really noticing decline. They're not able to communicate necessarily with their loved ones, with their family. They don't recognize family, cannot complete their own activities of daily living, bathing, dressing, eating, transferring, toileting, mobility. If you lose three of those functions, that qualifies you for hospice care.
Hmm.
A palliative performance scale. That's looking to see that, as we all are right now, probably at 100%, but that scale goes down as you lose abilities to do forth your own daily routine. So when you no longer can get up and walk by yourself unassisted, that breaks you down to about a 50. When you're more bed to chair bound, that's about a 40. When you're bed bound, that's a 30. So
Mhm.
those all qualify you for hospice care. Now,
Mhm.
hospice is a medically reimbursed benefit. The Medicare benefit was signed into order by President Ronald Reagan in 1979, I believe.
Mhm.
And Congresswoman Meeks out of Florida, African American lady, was very big and instrumental in getting that order presented to the president and getting it signed.
Mhm.
And by that, it means that everybody who is now in hospice care, their care is covered. So if you have a medical condition that requires hospice, everything related to that condition, your medicines are now covered and paid for. That is big in our community when you have people who are taking multiple medications, polypharmacy, if you will, and they're making that trip to the pharmacy, have to decide whether to get their prescriptions filled or buy some food, rather
Mhm.
than pay a bill or get their medications.
Right.
So now you're taking that burden off the family and the patient. You now might have a person who can't get back and forth to a physician, hadn't had health care. Most hospice companies will offer indigent care. So that means you don't have to pay for this. This is a Medicare benefit, and then the companies will take on patients in and of their own to provide the care that the patient needs and deserves. So you're not coming out of pocket paying anybody for this. You now have a physician who is overseeing the team and making treatment recommendations and prescribing medications for the patient, adjusting dosages. A
Mhm.
nurse goes by and sees the patient on a weekly basis. Now, there's an aspect of care where they might be going by daily if needed. I'll get to that in a moment.
Mhm.
There's also a home health aide that can come in and help with those activities of daily living, dressing, bathing, eating. Now, if any of you have been a caregiver, and most of us, as we transition through life, we go through a part called the sandwich generation, where you're taking care of your own family, but then you're also looking in on your parents. And that can be stressful and straining. So imagine now you have somebody who's trained to actually come in and do those activities, taking that burden off of your table, allowing you to be the child, the loved one, rather than being the caregiver as well.
Mhm.
Years ago, we took care of our grandfather, and I had to call my brother one day and say, "Hey, who could we pay to do this? I'm too old for this." And because it's rough, it's a strain. So
Right.
you have that individual. A chaplain can come by, back to your question about the spirituality. And my recommendation is, even if your uncle is, the greatest pastor in the world, he probably is not trained in end of life care. So go ahead and bring that hospice chaplain on board as well, and go ahead and get both aspects of that spiritual world taken care of for you. There's a social worker that's part of the hospice team. Many of us have not gone through our preparation for end of life. We may not have a will in place. We may not have our advanced directives in place. We may not have a plot picked out for our services. So
Mhm.
the social worker can help with that, can help get benefits. In most states, there's a Medicaid component called CCSP, and that's what it's called in Georgia, where they can get aides to come in as well. We have a veterans liaison specifically with VITAS. So the aforementioned potential patient who's in the VA system right now, sometimes we don't know that the patient is a veteran. So the veterans liaison can find out that information and get those veterans benefits that he or she earned during their time of service, and get those benefits and still for the family. Sometimes it's an economic component that the spouse may not have known about, it is now able to get to help take care of their loved one and the rest of the family. So all of these things take place. There's also a volunteer. So oftentimes your high school students, your college pre-med students, they can get their service hours that allow them to apply to medical school. They can be a volunteer with a hospice company, going in and helping somebody in their time of need, to give the caregiver a break for an hour or two. The volunteer doesn't administer any medicines. They're simply there to be a listening ear, maybe to play some board games, play some music. Oftentimes people who have been involved with hospice, they enjoyed the services so much that they come back and offer their skills as a volunteer in remembrance of their loved one who passed away in hospice care. There could be a music therapist, and music therapists are actually masters of their instruments. They have gone to college, they've gotten degrees in how to address crisis areas. So they're not just coming in and playing music, they're playing music with a purpose for agitation, depression, anxiety, um, trouble breathing. They're calming the individual down through their music therapy. So all of these things are available through the hospice benefit. You might need to get uh, gloves and chucks, we call them, to place under them for incontinence, to
Mhm.
change the patient out. All of this is a covered benefit. Hospital bed, medical equipment can be brought in, geriatric chairs, wheelchairs, oxygen. So all of this is covered and provided through the hospice benefit. And in the home, you don't necessarily go to a place wherever that person calls home, a traditional home, a skilled nursing facility, an assisted living facility. Wherever that person calls home is where this care is carried out.
Yeah.
I
Yeah,
know
that
that's
was
a
that
mouthful
was
for you.
Go ahead. Yeah, that was good. That was a good summation. I loved it. That was going to be my question. Whether if the patient, if you said it was a home But if they went to a nursing home, would it be the same coverage in a nursing home as opposed to the person's home?
Yes. So if a person is in a nursing facility, that's where the hospice company and the nursing facility, they have an agreement. And so that the nursing facility knows that on, say, Monday, Wednesday, Friday, the hospice aide is going to come through. So now the nursing facility can focus their aides and other patients, expanding the care and needs for everybody within that facility. The nurse comes in and sees the patient there.
Mm-hmm.
The physician for the hospice team is making decisions and in conjunction with the facility physician as well.
Mm-hmm.
But mainly that patient is under the hospice realm. So of
Mm-hmm.
course, anytime an emergency comes up, the physician who's there is going to make a decision on that patient's behalf.
Right.
And the goal, as you gentlemen who are doing inpatient care know, in this day and age, if you get readmissions into the hospice, into the hospital, then the physician can get dinged for multiple presentations on the same problem.
Yes.
The facility can get a reprimand letter for why they're just sending patients repeatedly to the hospital. So having the hospice team on board to notify the hospice nurse first, 24 hours a day, you can reach that hospice team. Now, of course, it may not be the person you see at 3 o'clock in the afternoon, but it will be a nurse and a physician available all through the night and holidays as well to make decisions. Keep the person out of the hospital, keep the person at home or in the facility. The nurse can come out and make a visit and then determine what needs to be done for that patient's care.
Mm-hmm. Mm-hmm.
And the medications that are covered by hospice, they're shipped to the patient's home. You don't even have to go to the pharmacy to pick them up.
Mm-hmm. You know, another thing I was going to ask you about was caregivers' education. You know,
Mhm.
we're I understand because even as a physician, when my parents or my wife's parents were at that stage, even as physicians, we needed training. It's not
Yes.
like I know how to turn, someone who's bedridden to how to turn them so that we're not, hurting them, or how to, change the sheets while still laying in bed.
Oh, yeah.
There is a lot to learn as far as properly taking care of someone at home. How does that come about? How does that education come about? To train the families themselves how to take care of that patient, because it's a lot. It's a lot.
Well, one, you do train. You always first find out what is the level of that family's capabilities.
Mm,
And you might be surprised as to how many doctors, nurses, and CNAs and HAs are now caregivers for their own families. So they have some skills.
mm-hmm,
But as I admitted earlier, as a physician, like you said for yourself, I tell my family and say, we need somebody else to do this, all this lifting and pushing and pulling. That's tough. So that's where the home health aide comes in to, one, alleviate that burden from the family. But of course, they cannot be there all 7 days of a week.
right.
So that's when they can then show the caregiver, whoever is there, this is how you do this particular maneuver. This is what's best for your parent, your loved one. And then depending upon the patient's payer sources, if they do have that CCSP program from the state funded, they can have caregivers coming in opposite days of the hospice team. So that way they get more coverage. And then of course, there's always ways to pay for these sources too. You
Mm,
do have home health companies that can come out, but of course that is an out-of-pocket expense. And as a sidebar, as maybe for a future topic, you have somebody come in talking about long-term care insurance.
mm,
It's a policy that we can get for ourselves, for our loved ones, where when that time comes when you cannot perform your activities of daily living, your PPS scale does to decrease, you can pay somebody to come in and care for you. And the good thing about that particular program is that you can pay whomever you want. It can be your nephew trying to put some money into his pocket. It can be a good friend of the family who has a stake in your care and treatment, and as well as could benefit from some extra income. They can come in and do it, as opposed to when you go through some of the state programs, the person that gets the money has to actually be trained and certified
mm,
in medical assisting or CNA skills.
mm,
So the long-term care policy that you pay for out of your own pocket, you get set up. The sooner you get it done, the younger you are, the lower the premiums. but then you can turn around and reimburse whomever you'd like.
Excellent. Let's talk about pain meds because this is a big issue, I think. As far as some patients, um, end of life is very painful.
Yes,
And how do we handle that? How do as far as being at home, having to administer these pain meds, if the family being comfortable with that. You don't want to give too much because you'll overdo it, but you don't want to get, you don't want to it's a difficult situation. How do we
sure.
handle that as far as pain meds are concerned?
Well, as you're pointing out, it's a tough call. If you don't medicate at all, that's not good. If you over medicate, that's not good. Very fine line that needs to be walked. So, first, acknowledging that pain does exist. Many of us, if the person doesn't look like they're in pain, then we don't feel their pain. So, we have to acknowledge that pain. That's one of the first components of end of life care is to control pain.
Mm.
In the presentations, there are about 20 or so symptoms that a person can experience at the end of life, and pain is so significant it gets its own teaching module where the other symptoms are all lumped together. So, with that being said, my father came time to place him in hospice care. Call my uncle up, say, "Hey, uncle, I had to go ahead and place Pop in the hospice." His first commentary was, "Don't let them give them that morphine." And I
Mm.
looked at the phone and
Mm.
said to him, "Hey, you do know what I do, right?" So you have to get that comfort level with the patient sometimes and with the family members at other times. And so find out if there is a pushback or reluctance, where is that stemming from? Now, with most men, we're trained to, not let our emotions show, to not admit pain. That's a sign of weakness. So you have to go ahead and allow that person to say, "Hey, if you're hurting, go ahead and say so. There's no shame in this. We're here to help you."
Mhm.
We actually have a whole module for veterans. So we have all of our military veterans and especially our Marine Corps, again, no pain, no gain. So you have that, Chief Master Sergeant who's now at the end of life. You have to go ahead and give him permission to admit that something hurts.
Mhm.
You can also have somebody who had an addictive lifestyle and they overcame their addiction. They went through that 12-step program. They've lived that and walked that walk for so many years. And now you come to them, talk about pain medications, controlled substances, narcotics. They don't really relapse to that person.
Mhm.
You have to remind them that unfortunately they're at end of life now. And getting addicted, one, we're going to help them prevent that from happening in the first place. But two, even if they become addicted to it, their time unfortunately has been cut short. We'd rather them be comfortable and out of pain as much as possible than hurting unnecessarily.
Mhm.
So that conversation can also spill over to the family member who may not know that their loved one even served in the military. They might have been in the military before they met their spouse and got together and started a family and never talked about it, especially our Vietnam era veterans. They don't talk about that particular time of their lives.
Mhm.
You may also have the caregiver, the child who knows that daddy was a mean drunk in those days when he was a drinking man and don't want to be on the medication now. So you have to find that information out, comfort the caregiver, the patient, the loved ones, and then compromise. Well, let's try the least potent, maybe, of the medications, the least habit forming and addicting of medications, and
Mhm.
implement that course of care and treatment, and then observe for effectiveness. You can, in hospice, you only administer medicines at 15-day increments anyway. You don't give 30-day or 90-day supplies of medicine. You only give 15. With the
Mhm.
pain medication, well, let's just dispense it week to week, and we'll see how you do. There's 4 levels of hospice care. There's in-home hospice,
Mhm.
there's crisis care when somebody's admitted in a crisis of some sort. So say it's pain. What that now does is that you get a nurse that is in the facility, in the home, 24 hours to monitor and alleviate that pain symptom. Adjust the dosage of the medication, administer it accordingly, show the family members what to look for with pain,
Mhm.
show them how to adjust the dose of medicine. And then once that patient's pain is stabilized, you can now get out of crisis mode, go back to your regular course of care and treatment, and the family can take over the pain management. So those are ways to try to address pain, but the real key is always is to address it.
Mhm. Mhm. Excellent. Excellent. That is one thing in the ICU. A lot of times we see patients at the end of life, and the family decide not to do very much more or do anything more. and we extubate the patient or take them off the ventilator, and most of these
Mhm.
patients are critically ill. And if they, you know, just because you've taken them off the ventilator doesn't mean that they're going to expire. They're still,
Right.
we call it comfort care. And when
Mhm.
you talked about that morphine, yes, you know, at that particular point, we stop feeding, we stop any further medication, but we do give morphine, not to the point that it would suppress the respirations or the patient breathing, but enough that the patient's not in pain, and let nature take its course. So that's one of those areas of comfort care that we see in the ICU quite often when a family decides to, you know, to take a patient off the ventilator and let nature take its course. Let me talk about as far as hospice is concerned. Is there a time limit with hospice? You know, is there like you can only have it for 6 months, and how does that go? Because there are patients that have been diagnosed that you only have 3 months left, and 2 years later they're still alive. You know what I mean? So we as physicians, we can give our opinion as to what
Yeah.
we think your lifespan's going to be, but guess what? You know. We don't have a number that we're dialing to the man upstairs to tell you exactly, you know, when your number's up or when your date is. So how do we handle that?
Exactly. Well, first and foremost, the hospice benefit gives us a 6-month window.
Hmm.
So when it's determined that in your years of expertise and the knowledge that you've gained, you've seen this particular disease process, that at this point, the patients, you'd be surprised if 6 months from now they were still alive. So you call on the hospice team, come in and take over. Keep in mind that sometimes the patients that you're seeing in the hospital in the ICU, they came in urgently. They might have been homeless and living in a shelter. They may not have been going to their physicians appropriately, but now they're in hospice care. They've got that hospice team, doctor, nurse, home health aide, medications. So all this care is coming on board now, and they actually perk up.
Hmm.
They're going to live longer. So part of the hospice team, we meet every week and talk
Hmm.
about each patient.
Right.
Now, remember, the nurses are communicating daily with the physicians. The home health aides are communicating regularly with the nurses. So there's communication going back and forth every day on each patient. We actually, as a team, converse on about everybody every week. And then there's a hospice term. So when you first come into hospice care, you get that 90 days. But after that, is every 30 days, you have to be recertified into care. And the goal is to document decline. So that's one of the things that we as the clinicians have to learn. We're no longer treating for cure, we're no longer looking for improvement, we're documenting decline. So the patient is no longer talking, no longer going to eat at the dinner table, no longer able to take themselves to the restroom. All that qualifies as to why they stay on hospice care. So that may be for years at a time. Currently, the most famous individual that we talk about is former President Jimmy Carter, who was on hospice care for 680 days. Quick arithmetic, that's 2.5 years that he was in hospice care. Formerly the leader of the free world, it wasn't on it for an economic benefit, but also for the actual care that he received.
Hmm.
His beloved Rosalind, she was admitted in the hospice, was only on service for a couple of months, unfortunately, in her case. So that shows where the earlier we as the physician makes the diagnosis and the presentation, the better for everyone. Now coming all the way down to our community. So if 6 months is the guideline, the recommendation, the average length of stay on hospice care is only 90 days. So that means even nationwide, all races, cultures, creeds are not getting the full 6-month benefit. But for people of color, that drops down to an average length of stay of 7 days. And oftentimes, when we are admitted into hospice, it's in a crisis mode. So, say a patient got admitted yesterday in crisis mode, they may pass away tomorrow and never get the full benefit of care. So, the earlier we as physicians acknowledge that this patient is at this time of need, the longer length of stay for the patient, the better quality of care for the patient and the family members, the better preparation for everybody involved. So to now summarize the answer, it's a 6-month time frame with unlimited recertification periods.
Mhm.
Now, lo and behold, there's that one person every now and again that rebounds so successfully that they're not showing a decline during the recertification periods. We graduate them from hospice. You get discharged. But
Mhm.
hey, what does that mean? It means you're living. And you're always welcome to come back to that hospice team when that decline turns back around.
Right. Right. So the thing of it is that you have to be assessed, and you be assessed by physicians, and I guess it's the hospice physician as well as the primary care physician come together and determine, yeah, we're going to put in for hospice. Then that has to be assessed, and then the hospice has to accept. Now, who accepts actually? The hospice accepts, or the physicians accept? How does that how does that go?
Well, a physician typically works with each hospice company. Each hospice company has a medical director and or team physicians, depending upon how big their programs are.
Okay.
And then if the patient does have a primary treating physician in the community or a hospital-based physician who is making this decision, that's when that individual makes the recommendation for hospice care.
Right.
So then the hospice team has what's called an admissions team that goes out, assesses the patient, call the admitting physician for the hospice team. So for example, I am a team physician as well. So the nurses call me and say, I've got a patient at so-and-so hospital. They're this age with this diagnosis, and this has been their recent course of care and treatment. And I
Right.
say, yes, they meet the criteria, admit them in the hospice. Now, I also am what's called the certifying physician for our program. So that means I then, on a daily basis, get patients from all of our teams. We have 4 teams with our current program in Atlanta. And I look through the information and document that the patient does indeed meet the Medicare criteria for hospice care. So
Hmm.
all this is how the patients get admitted into hospice, get
Right.
referred by the treating physician or the family. Family members can make that code call as well to a hospice company. You know, they've heard of hospice, they know of a company locally. They call and say, "Hey, my mother is looking like this. What do you think?" And then the hospice admissions team comes out, and the ball gets rolling.
Right. Right. That Dr. Court, I see you have your
Yeah,
hand up. Thank you.
yeah. I sometimes hear from patients and family members that once the patient goes on hospice and say if they start to have a symptom, like a cough or shortness of breath, that usually what happens is they start morphine until every hour or so. Is that usually what happens, or is it based on
Not
depends
usually.
on the symptoms?
And typically in this case, I'll use myself and my program because I'm also the associate medical director. So we have a meetings within ourselves and the different doctors. There's 3 of us. We all treat similarly, and we always treat the symptoms. So if the person is simply coughing, well, take a history, as we all learned way back in medical school. How long have they had the cough? Georgia here is very bad with pollen and seasonal allergies. This current time of year is ragweed. Does the person have seasonal allergies? What are they taking for that? Do they need to be on something? Do they have asthma? Were they ever a cigarette smoker and have COPD? What's causing that cough? Were they visited by their grandchildren last week who go to daycare and now they picked up something from the cesspool known as daycare and brought it back home to granddad? So it's just treat the cough. Do they need an antibiotic? Do they need an antitussive? Do they need decongestant? So never, typically do you start morphine. At least I do not. Our program does not, because the person coughed.
Mhm.
Good
Morphine
to
is
hear
when,
that.
thank you. Morphine is when they're really showing respiratory distress or pain.
Yeah, yeah. That morphine, I think in our community that's one
We
of
hear that
those,
all the time.
you know what I mean?
Mm.
That's one of those key words that just kind of and everybody backs off, because I think yeah, and rightly so. I mean, just think of our community at number one, holistic medicine is a big part of our community. It really is. And number one. And number two is that if you look at most of the diseases out there that are fatal diseases, I mean, we're at the top of the list. So
Oh, yeah.
we get diagnosed late, we have more aggressive, um, the diseases are more aggressive. Um,
Mhm.
and most likely we're going to be the first ones dying from those diseases. So there is a lot of, I should say, back in the back of our minds a lot of psychological, you know, difficulties we're trying to deal with. Anytime someone approaches us with, things like morphine or things like that, that would be a question mark of whether it's going to be good for us or bad for us, in our minds, not as far as the physician is concerned. Dr. Patrick Anderson, how you doing there, brother?
I'm okay. Good to be here. I had marathon rounds
I hear
this
you.
morning, and I tried my best, but it just wasn't happening.
I hear you,
Um,
brother. We
yeah.
appreciate you. Can you introduce yourself?
Yes, Dr. Blake, nice to meet you, sir. I'm Dr. Anderson, Pat Anderson. I'm a gynecologic oncologist. I practice in the Barnabas Health System, primarily out of Newark Methuselah Medical Center.
He's modest. He's the director of being very modest, Patrick. This brother's bad, but he welcome, welcome, welcome.
Yeah.
All righty. So the thing of it is that what I'd like to do right now, there's a question that came through Dr. Blake, and I'm going to read it to you.
Okay.
Why is it so hard to qualify for hospice? My husband had Alzheimer's, and it took 3 different tries before he was accepted. He was totally helpless when it came to activities of daily life, but his vitals were good. He was accepted 6 weeks before he expired or before he died. And in reading this, I can understand, but can you give us what you think as far as this is concerned? Because I can imagine that this is not an uncommon situation.
Sure. Well, definitely, first of all, sorry that it was so difficult for your husband to get the care and treatment that he needed and deserved, and for you as well. Now, this is probably going to be unique to different hospice companies. So I'm not sure if those 3 tries were the same company or if it was 3 different companies or not. But just like in any other aspect of healthcare, when you don't get or hear what you think you need or deserve, please always seek a second opinion. As physicians, we should welcome a second opinion because we're doing what's right at first. Then that second opinion should echo what we previously said. So now, as far as with dementia, you typically, if you cannot do 3 out of those 6 activities of daily living, that should suffice. With dementia, we're looking for something also called a FAST scale. That looks at the patient's ability to communicate, to recognize, to do different aspects of living. So are they wanderers? So that goes usually on a scale of 6 and 7. And so for the Alzheimer's type of diagnosis, you typically want to have a FAST of 7, and then it has letters A, B, C that go with that. So with that positive palliative scale that we spoke about being 50 or less, the FAST score being 7 or more, with the patient not doing activities of their daily living, even if the vitals are good, that still qualifies that individual for hospice care. So you would have to really look at those companies and what their criteria are or were at that time to see what wasn't being met and their abilities to care for that particular unique patient. So always, seek out other aspects, other recommendations if you don't get something the first time.
I got a question to ask you, and I meant to ask this earlier. All outpatient, no, I shouldn't say hospice companies, they're not all the same. They don't all offer the same amount of care or are able to handle all types of patients. So, and the criteria for them accepting it may be different for depending on the hospice company itself.
Yes, there are criteria that are nationwide that satisfy the hospice benefit, but then within each category of diagnosis, it can be Alzheimer's, COPD, cancers, heart disease, all these disease processes qualify for hospice care. But then it's the company. Now, each state has different criteria for hospice care. Georgia, for example, is a non-certificate of need state. Florida, for example, is a certificate of need state. So in Florida, you can't just open a hospice company. You have to get the okay from the state. Then you have to meet certain criteria and guidelines. In Georgia, I can go ahead and get other members from the other aspects of the team and start a hospice next week if I so desired. without having to go and get permission from the state. Now, of course, you have to get licensure, but not permission. So in Georgia, Atlanta metropolitan area, there's over 100 different hospices. So depending upon the size of the company, they may not have the personnel to cover different things like taking care of indigent patients, offering to continue dialysis, offering to continue intubation care at the home, because the company can't sustain that cost that goes with that. So that's where, and I saw that these was 3 different companies that the young lady had to deal with, and that there had to have been something else that was going on. But 6 weeks, when we say that it should be 6 months, there was definitely something missed, unfortunately.
Yes, thank you. Patrick, I see your hand up, please.
Yes, Dr. Blake, the whole palliative care, hospice aspect of patient care, as Dr. Bay knows, is so dear to my heart, and is such an integral part of my practice. And, at a time when we're seeing a lot of cancers in younger and younger patients who are coming in with advanced stage disease. And Omar, Dr. Bay, Dr. Blake, from a support care perspective, he does in the past some of my critical care. Now he doesn't do that so much, but he does most of my nutrition and metabolic services. One of the struggles I have, and it's a spectrum, right? It's having the conversation surrounding palliative care. Well, even earlier on, having a discussion with respect to the nature of the disease, the advance of the disease, how advanced the disease is, prognosis, palliative care, and ultimately, in many cases, we know the hospice conversation has to happen. How soon in the patient engagement do you recommend that goals of care conversation to begin?
Okay, wonderful term there, Dr. Anderson. Thank you for that segue. Goals of care, very important component of our care as physicians. Now, as a gynecological oncologist, you're dealing with the sickest of the sick. I don't know if you've ever heard of Dr. Cyril Span. He's my
Oh,
guy. He's
Sarah and I go far back. He mentored me. He pounded on me. I even think he was one of my examiners in my board.
he may have been. I mean, he's a great guy. He took
Great
care of my
man. Yes.
mother. Yes, he's active in our medical societies here, and
Yes.
he's still doing his thing.
Yes.
So that shows you my input into gynecological oncology. So
Yes.
very near and dear to the young ladies there, because yes, they're getting diagnosed with disease processes earlier in life. I had a 17-year-old cousin who had cervical cancer. She turned 18 on Sunday and passed away on Tuesday. This was way back in 1995. So definitely going on there. So that conversation for goals of care is part of what we spoke about a little earlier about what does the patient know about their disease. So as you're talking with them, you're coming down with their diagnosis, you're asking them what they already know, and then you're educating them as they go along. And that's so as soon as you make the diagnosis, especially in your specific area of expertise, you probably want to start that after you see what the diagnosis is when the pathology comes through. And that you get the patient and their loved ones ready. And then you have this conversation. You want to do it in a quiet setting. So not necessarily in the two patient room. If you have a single room or if you have a conference room that's available, you want to bring in the family members. You want to bring in that spiritual community that Dr. Bay asked about beforehand, and then go ahead and prepare to ask what is known about the disease. What do they want to know about the disease process? Explain to them what you have seen in your expertise with that specific diagnosis and what the outcomes can be, and then let it come out. Do they have their will in place? Do they have their 5 wishes in place, their advanced care directive, whatever aspect that you want to use? Do they want to be intubated or not? And then heroic measurements of treatment, get all of that known and designed and outlined. So when that time does come, the family members are now relieved of that burden of making that choice and that decision. So hopefully that answers your question. In my opinion, when you
Yeah.
make that diagnosis, start that conversation.
Yeah, but again, it's an interesting conundrum because oftentimes once you begin that conversation, and a lot of times in our community, there's that element of trust, right?
Yes.
And once you start that conversation, then across the room, you see the wheels turning, and you start to feel that they're questioning how aggressive, how genuine, how trustworthy is are we, but we meaning patient and myself, is going to be of each other, and asking the question, are you doing as much as you can for me? From a physician's perspective, you struggle with not blunting hope. You struggle with not encouraging the fight. And how do you communicate that in a manner that the patient understands that I'm not doing any of that? I'm not taking away hope. I'm encouraging you to fight. I'm encouraging you to engage. I'm encouraging you to be educated, because we all know at the end of the day, we are going to die. But no matter how old we are, we're never ready for it, right? It's kind of like retirement. When my family said, "Well, Dad, when are you going to retire?" I said, "I work until I can't," right? Right? So
Mhm.
it's the same thing, or at least a similar thing, right? And the struggle is, how do you differentiate the goals of care conversation from I will continue to push and fight and practice with every tool that I have available to me to give you the best outcome.
Well, that's why they call it the practice of medicine, Dr.
Right,
Anderson.
right,
We're going to keep practicing this conversation as long as we keep on working.
right.
And we're probably not going to get it 100% right
Hmm.
each and every time, but we'll get it right for that particular patient. So that's where you ask again of the patient what they know, and then you give them what you know and what you've experienced. And maybe you focus your commentary as to, well, we can do, and first, like, hopefully you are doing this already. You're telling them, I'm here for you. I'm here
Hmm.
to do what you decide. That's why we're having this conversation. This is what I can do, because people watch television, they see all these shows, these heroic treatments that just aren't real. We know this. They unfortunately don't. So you might say, well, 95% of the patients who go through these treatments have a good outcome, and they
Hmm.
may want to go for it. But if you flip and say, well, 95% of the patients don't have a good outcome, then they might change their minds. And keeping in mind also, you let them know this conversation is not once. It's not whatever we decide today is going to be the end of it. We can come back and reestablish, recommunicate again at whatever interval you decide. You might start the conversation and you notice across the room a lot of emotion. We'll say, well, how about we go ahead and table this and we come back in a couple of weeks and we resume.
Hmm.
Or if you do get some decisions made, well, we can see you back in a month. We can see you back in 6 months. Just whatever time interval that you might think is appropriate, that the patient would actually have time to still be with us, thank goodness, and they can adjust. They may decide today they want to do everything, and after they've gone through several rounds of chemotherapy treatments and radiation treatments, and unfortunately get some of the untoward side effects, they may come back and say, hey, doc, I don't want this anymore.
Hmm.
So it sounds like you're saying you're not going to push anything on the patient. You're going to do all that you can. Just find ways to use your vocabulary and your relationship with that person to try to address it. Because if you're called in sideways on my patient, you just met them that day before, like I did too. You've got to get that relationship before you
Hmm.
can have that harsh conversation
Yes.
with them.
True, true. Mhm. Very, very good. Very good. Dr. Court, your hands up.
Yes, I am. But Dr. Blake, what should I use to have a patient qualify for hospice? Just ADLs or the FAST score? And if so, if we're using the FAST score, how many components of that do you really need? Is there a number?
Yes. Well, FAST is only for dementia patients.
Only
So
for
if you have
dementia.
a patient that's actually Alzheimer's type dementia, then a FAST score of 7A as a minimum will qualify for that. Now, if they have a
And what would,
comorbidity, I'm sorry, yes, sir.
and what would be those seven or so that are required in order to
It's not
just for
seven things.
dementia?
Fast of seven. So when you have a fast score of seven, it means you're not having any intelligible speech. You're not able to
Okay.
toilet yourself. You're not recognizing family. So that person is pretty much going to be homebound at that point. Now, if they have a comorbidity that you're also including with their diagnosis, say protein calorie malnutrition, because dementia patients, unfortunately, they stop eating, they start wasting away, losing weight, then you can have the FAST score maybe be a 6 as opposed to the 7, because they have something else that is also causing their decline.
Hmm.
Because
And
we
then,
frequently see patients with dementia, and we're told, well, the patient really belonged to hospice. It's a problem for many of us to determine, well, what should you do?
well, you
The
definitely want
fact
to
that
make that
dementia doesn't really
recommendation.
mean you need to be on hospice.
No, it depends on, again, that scale. So if you have your patients on donepezil and memantine and they're doing fine, that's the whole purpose of those medicines that I was advised when they first hit the market, to slow down the memory impairment and keep them home longer. But when that decline starts to happen, even on medication, well, that's when you might want to withdraw the medicine, one, because it's no longer being effective. And that, along with FAST scores and PPS scores and activities of daily living, should qualify that patient to be in hospice care. So you definitely want to communicate with the local hospice companies. And maybe it's time for the companies in your area to sometimes to do what's called a pack meeting, where they'll bring in doctors like we're doing right now, and you can ask the unique programs or company in your area what their criteria are, what are they looking for, so that now you know who to send to them. So if you have a hospice team, a hospice company up there, find they should have a marketing department who's coming to your practice, who's coming to your facility to talk to you, to solicit, care and treatment of your patients. They should be coming to you, and then they should also let you know what the criteria are for their unique company.
Mhm.
Good.
Excellent,
Thanks.
excellent. You know what we need to do? Time is flying. We're at halftime, so let me do this. Let everybody introduce themselves again, because I'm sure that there may be people that have come in. And Dr. Blake, can you introduce yourself? And we're just going to go across the top screen and introduce the physicians, and then we'll get going again, and I'll do my second half spiel.
Okay. Again, my name is David Blake. I'm a family medicine physician practicing out of Atlanta, Georgia, for over 30 years. 24 of those have been in the end of life hospice realm. Specifically, the last 16 years of Vitas Healthcare. Specifically, I get a chance to travel across the country, speaking at programs like this at other Vitas facilities, programs in different cities and states, at various nursing conferences. I've had a chance to lecture for the National Black Nurses Association, the Licensed Practical Nurses Association, and next week I'll be traveling to speak at American Men in Nursing. So get a chance to have this conversation quite a lot with different groups and different cultures and different areas of the United States, because this is a nationwide issue, not just in Atlanta, for example.
Excellent, excellent. Dr. Court, please.
Dr. James Court. My practice is located in East Orange, New Jersey. My specialty is internal medicine. I only treat adults.
All righty. Dr. Patrick Anderson.
Yes, Patrick Anderson. I'm a gynecologic oncologist. I take care of women with cancer of the female genital tract or the reproductive system. I practice in the Barnabas Health System in Newark, New Jersey.
All right, thank you, Patrick. And I'm Dr. Omar Bey, retired pulmonary critical care physician, and now Director of Nutritional Support for the Intensive Care Unit at Beth Israel Medical Center. Um, I just want to state out there, please type in your questions. Um, do not hesitate. No questions too small, no questions too large. We're going to try to answer them. So get to the keys and type them in. Note that our Doctor's Lounge is every second Saturday at 1 o'clock. All you have to do is go to OBHealthy, as you know, but please let others know, and click the Doctors tab. Come right in, and you just have to sign in, and we will try to answer your medical questions, or hopefully we're here discussing something that's, educational as far as healthcare is concerned for the Black community. Please, yeah, our past webinars are on YouTube. So all you have to do is either go to the website and hit our YouTube sign or the little camera sign on the physician's page, and you will see all of our past webinars. So many different diagnoses. Please go and check them out. And hit subscribe on that YouTube so that we can continue to bring this to you. The most important thing that I can say, and I'll always repeat this, is please do not change any aspect of your medical care until you consult your physician, because only your doctor, truly only your doctor, can best take care of you from a medical perspective. Okay. Yeah, let's keep going. Patrick, you got your hand up again, brother. I want to go straight to you.
Yeah, I feel like I need to move in with Dr. Blake because there's just so much in my head that I want to ask you. You know, where Dr. Court and I, we have a special relationship. He adopted me when my dad passed away.
That's good.
So
And
he
you're still a good son, sir. You're still son.
So, but for what Dr. Bay and I do, we take the acute, we transition it into somewhat of a chronic phase, and then that chronic phase becomes an end of life conversation, right? And that's the typical model that I'm used to. But is there a program where you actually take that relatively healthy adult who is in the latter years, but functional, live at home, family or by themselves? Is there a structure where that person, through their primary care provider, can be engaged in a program that's educational, that addresses wellness, but also have the palliative care / end of life chain attached to it, so it becomes somewhat of a continuum and an easier transition?
I've not heard a specific title put to that sort of a program, but we could probably create something that starts with advanced directives. So that's where you do want to have that conversation with that functioning adult who, as you astutely said, and none of us getting out of here alive. So we do have to pass away at some time, hopefully later than sooner. But stuff happens as well. So
Right.
getting that person prepared is what's good for the person and for the family members. And so whatever directives they give, the next time you see them, can also be changed. So if they're relatively healthy, you might want to revisit that on an annual basis when they come in for their annual evaluation. Let's talk about your advanced directive. Anything you want to change? Do you need to change your executor, if you will, who's going to make that decision for you? So get that advanced directive in place. Mentioned earlier about long-term care insurance. If they don't have a policy in place, well, who's going to take care of them when the time comes and if needed? And the good thing about long-term care programs is you can get a hybrid one, which means if you live to be 102 and pass away peacefully in your sleep, your heirs get full benefit. If indeed you have some sort of disease process, you become bedbound for the next couple of years and you require in-home care, then you can start paying for that care to come in and be taken care of for you to keep you at home as opposed to a nursing home. So having that conversation while somebody is, hale and hearty, if you will, is probably a good thing. So that way they know what to expect. Their family members already know what the decisions were for mom, dad, and they don't have to make that decision in the midst of a crisis or fight over what's going to happen either. You have multiple children and you always have that one child who wasn't part of the care and treatment. The children have been there doing the heavy lifting. Now it comes to the end and here comes the ne'er-do-well sibling want to change everything at the last minute. Well, you have that document. This is what mama wanted. This is what we're going to do. It's a legal document, by the way.
Alrighty. So
Yeah, I was just thinking from an advocacy perspective. I even some of my cancer patients who are living longer, and now we're now focusing on not surviving, but to tell someone who is getting into that 70s, 80s that, I appreciate the fact that you're surviving. No, I want you to thrive, right? And they're thinking, but I'm 80 years old. That patient, I'm thinking, what do they do for on a day-to-day? They wake up, they have breakfast, then what? Is there a program where they get some physical therapy, some where they go to the mall, like a system where assisted ride or with an attendant, they go to the mall? Because these are not individuals who, well, and some of them do, but some don't, a lot don't. You would want to be out there by themselves, right? They go to day programs where they do things that, promote cognitive maintenance, right? Um, but with the understanding that the day they wake up and they're altered, it's a seamless transition into seeing a neurologist, seeing someone who's going to do a cognitive evaluation, a psychiatrist. And should we decide or deem that they're becoming, having dementia, then there's a seamless program that get them into, managing the dementia. And start having that hospice conversation so it never becomes an issue that's 6 weeks out upon request. One is struggling to get their loved one into the system.
Yeah.
I am not aware of such a program. That sounds like something we really do need to start implementing in our communities. Something that might assist with that. Dr. Court, maybe you've heard of this as well, is remote patient monitoring, chronic care management, where the patients get called on a monthly basis. So
Yes.
maybe the physicians like Dr. Court, myself, we can make that part of the criteria for when they make that call to report back to us. Has there been any decline in the patient's care? Do they seem to be needing more care and treatment, so we can start that ball rolling towards neurology evaluation? So that's the main thing right now that I'm aware of that we might be able to use to the patient's benefit.
Telehealth.
I have a question. You had mentioned things like long-term care and stuff like that. Could you go over the 5 wishes? I think this is so important. We at Beth Israel, we have this whole printout that you could go on the floor, certain floors, and you can find this pamphlet that has 5 wishes in it. What is those? You know what I mean? What is that pamphlet that you're trying to put together, or patients should look at, or if someone comes into the hospital and they're critical, that hopefully they've already filled it out, but it may even have things in there that the family can kind of take a peek at and understand what the wishes of that patient was. It's important, especially if a patient comes in and they have a serious illness, but they're not, they're going to go home and they're going to do well for a period of time, but eventually that illness may catch up with them. It's important to fill out or have that family understand what the wishes of that person is, and it's called 5 wishes. Can you do you come in that contact with that sometimes?
I do, and mainly that's where our social work team comes into play.
Mm-hmm.
And that's why it's good to have it in place. But the good news is that, one, I'm glad that you know that 5 wishes exist. And what these 5 wishes are what 5 things does the patient want? Remember, this is always patient driven. So the sooner we get started while the patient is cognitively intact, can make a sound and wise decision and declaration, then great. And so it's such as things of, do you want to have heroic treatments or not at end of life? Do you want to be intubated, resuscitated? Do you want to have artificial nutrition? Do you want to have nasal gastric tubes, peg tubes, peripheral alimentation, those sorts of things? Who do you want to be your decision maker?
Mm-hmm.
Now, there's all kinds of individuals that can be the decision maker. It can be a spouse, it can be adult children over 18, it can be adult siblings, it can be your parents. And if the event that none of those individuals are available or around, then a surrogate can be appointed for you to make your decisions at that time. Now, only the patient then knows, will their spouse of 50 years be able to make that decision to terminate life-sustaining efforts when that time comes or not? And so maybe that person might not be who you would choose. Do you have a child who would be able to make that decision? You might need to call in a friend. I actually, my business colleague, he asked me to be his executor because he knows his family wouldn't be able to do it. So you need to have that person to make that decision. And so those are where the five wishes come in.
Mhm.
Again, you get to line up those five components. This too is a legally binding document without having to go through hours and thousands of dollars with a lawyer. When you do your five wishes, your advanced care planning, the recommendation is to put that document in a freezer bag and put it in your freezer. EMS teams are trained to learn to look to the freezer for that information, as opposed to rummaging through that kitchen junk drawer we all have, or the big Bible on the coffee table that's in Big Mama's house. You put it someplace where you know it's there. Have a copy with your primary physician. And if there's a local hospital that you always go to, it can be on file there as well. Get those five wishes in.
Mhm. Mhm.
So
Excellent, excellent.
Yeah,
this-
I think Dr. Blake, you use a term that I think may warrant some clarification when you say executor.
okay.
That may mean someone who have to manage your estate or handle or get your will probated. But from the medical standpoint, we're talking about a healthcare decision maker, right? That's not the
Thank you.
same, right?
No, no, no.
Yeah.
Thank you for that. We're talking about the medical proxy, because you can
Yeah.
have a power of attorney for healthcare and then a power of
Hmm.
attorney for your economics, for
Right.
finances.
Hmm.
Doesn't have to be the same person.
Right.
Mhm.
Right.
So you want the person who's making your medical decisions. So that individual is who you want to choose as part of your five wishes. That person who's going to say, Mama didn't want to be intubated, we're not going to do it.
Yeah.
Daddy didn't want to be have a tooth fading, so we're not going to do it.
Mhm. Mhm.
So that's
Excellent.
that person is going to have that authority to make that decision, who can carry it
Yeah.
out in the
Right.
time of
Right.
need.
Right.
Right. And that's the most important thing. Choose someone who can carry it out, if you understand what I'm saying, because you're asking a lot of that person. You're
Hmm.
asking that person that may be at odds with other people in the family, but they're sticking to what that particular patient wants or wanted
Hmm.
to be
Hmm.
done at this
Hmm.
stage in life.
Right.
And it's a difficult situation, but and I feel the patient has to choose someone who they feel can really do what they asked them to do. Yeah, yeah. Dr. Court, please, your hand.
Just a comment in terms of intubation. Many times the patients don't really understand that sometimes we have to intubate the patient to overcome a temporary situation. But if you put that on a list, we cannot do it. We have to understand why and when it's appropriate not to intubate.
Mm.
So when we're having that goals of care conversation, that's where we as the physicians can go ahead and try to break that down, and that we're going to intubate to protect the airway. And as soon as you're stabilized, we'll extubate, versus when we're doing for life sustaining measures and going to be mechanically ventilated with no thoughts of you being able to overcome and come off that device.
Mhm.
Hmm.
So
Yeah,
make
Simple.
sure that we make that part of our conversation, our input into that presentation.
right. And that can be stipulated within the five wishes. When you can write that in and say that, if I'm not to come off this ventilator, then please, then that's not what I want. But if it's a disease process that I know that with medications it's going to resolve and I can come off the ventilator, then that's appropriate. They would want that, and that's clear that it can be stipulated within the five wishes. True. We have a couple questions, and let's get to those. I came on late from another meeting, but how do you start to find hospice care for a loved one? That's the question. Is there a listing of reputable facilities, or does your medical doctor take this lead? So
Okay.
it's a good question.
Yes, it is. And first, keep in mind that there's not necessarily a hospice facility. Home hospice is where the person calls home. It's more of a philosophy than a place. So, yes, your physician should have some sort of communication and connection locally as to which hospice companies are there, which, in their humble opinion, might be the better one or ones to address. And then, as far as like at a facility, it's always been said that the patients, the caregivers, they have a choice. They should be given at least three companies to choose from. So, from a previous question, find out maybe the top 3 or 4 companies in your area, and then vet them out yourself if you so desire. Each hospice company should have a marketing team. They should have a admissions coordinator. They should have their local physicians. These companies might be doing programs in your community at area churches, um, might be doing programs at health fairs. So look to see if any of these companies are active in your community, if they're reaching out. And that might be some of the ones that you want to find out more information, because it shows that they're looking out for the community.
Thank you. The second question is, good day. I'm in Florida. Is palliative / hospice care covered under Medicare only and or Medicaid? Question mark.
Okay. It is the Medicare benefit. And as with all aspects of healthcare, it is driven by Medicare. So now each commercial company will also have Medicare components to their, not Medicare, I'm sorry, hospice components to their treatment. So you don't have to be of age or the ability to be on Medicare only if something happens. I've had patients with Kaiser, Aetna, Cigna, the various third-party payers, and then Medicaid. Yes, all of those companies do cover and support the hospice benefit.
Excellent, excellent. The thing of it is that we've covered so much here, but there, I just get the feeling sometimes with our people, African Americans, and that's where I'm going with this. That so much has happened with us throughout the years as far as experimental medications, experimental procedures that and I still hear it, believe it or not, that you're not going to experiment on me, that type thing. How do we handle that? Or do you have any advice on how to move forward as far as educating our people that these are different times? You know what I mean? But it's still within our culture big time as far as, I don't want you to experiment on me.
Well, that's probably going to be a conversation that we as physicians are going to endure for henceforward and forevermore. So that's going to be something that we have to get our own unique ways of communicating. So to say, first, acknowledging that those things did happen, we can't gloss over them, and then try to get that that bond of physician-patient care, that I'm here for you, I'm going to do what's best for you. Let's give this a chance. It's not, if you do indeed sign on for the service, you're stuck with it, by no means. But then they also say, well, here's how you can benefit. And you go through those things we spoke about, the whole team that's going to be a part of the patient's care, the economic components that are going to alleviate the family members of some of those burdens, the back and forth. My mother, we took her to the hospital, I think it was 2 occasions. The last time she told my brother and I don't want to go back. Okay, you're not going back. So it can alleviate going to hospitals and waiting in emergency rooms and being in a room by yourself. And during COVID, you couldn't even get visitors. So you could be home and have the medical care come to you through hospice. So show what those pluses are and see if they outweigh the negatives. And if the patient then gives you that chance, then make certain that you go ahead and expectations overproduce.
Yeah, definitely. I want to go back to, you said something about palliative care, and we covered that, but I just want to go back. You said something that palliative care is not paid for. It's not covered by insurance. If I'm correct. How do we get this? Why does it happen if it's not being covered, or if insurance is not paid, does not pay for it?
Well, that's where in a facility, like you said, you have your team, and then with hospice companies, realizing that everything that we do in healthcare should not be economically driven. Some things we do because it's right and so to do.
Mhm.
And that when you have a palliative patient, unfortunately, they're going to convert. So I work with our palliative team as well,
Okay.
and we meet on a weekly basis and discuss the patients. And once they begin to experience a show of decline, then they transition to hospice care.
Mhm.
So, kind of like, again, getting that trust from the question that was just asked, how do we get past the experimentation thoughts and components of it? Give us this opportunity to show you what we can do, how we can be helpful for you and your loved one. And then when the time and need comes, we'll also be here to take care of that end of life component.
All right.
Yeah.
So what you're talking about is, I understand in hospital because there are so many services in hospital. In the ICU, we do, I mean, palliative care is, that team is called just about on every critically ill patient that comes into the hospital because it allows us to key in on the services that may be needed, be it social worker, be it, talking to the family, be it, filling out the 5 wishes, whatever it is, we have that. But when you are someone as an outpatient, you know,
Mhm.
um, I just don't that primary care physician, how is he going to negotiate all these things that could come about that we can do in a hospital that can't be done at home? Is it that you call the hospice service and then they're thinking in the future till they'll come out and do this? How does it happen?
Mhm.
I'm just still a little confused.
Sure. So, say if you have a hospice company that has a palliative care team,
Right.
you can give a call as the primary physician and say, I have this person that's showing some evidence of decline, probably not ready for hospice yet. Can you provide palliative care? And then they'll say, well, no, we don't have that service. Well, thank you. And then you call the next. And then when you
Hmm.
find somebody that does have that particular program, then you can go further and see if now can go ahead and get your patient into that palliative care. And remembering too, they're still your patient. You're still seeing them as well. And
Hmm.
so if you notice a decline, the family members contact you and say, uncle is not looking good anymore, then you can go ahead and give the heads up to the palliative team.
Hmm.
And even when your patients are on hospice care as the primary physicians, you can still see that patient if you so desire.
Right.
And just keeping in mind that you cannot see them and bill for the hospice diagnosis. If you want to
Right.
just do a welfare check and have them come in on a monthly basis and see you, if you want to see them for their cough and colds, then you can bill for those.
Hmm.
You
Hmm.
can still maintain that relationship as the
Right.
physician, and you have the team send you notes from that weekly meeting that we spoke about, so you know what's happening with your patient.
Hmm. Hmm. All right then. All right. Now, at what point do you recommend from an outpatient or for a physician who's sitting in an office, they refer to a palliative? I mean, are there certain diagnoses that just key you, or is it that the patient is rapidly deteriorating, or what do you suggest for primary care doc so that or and then not even a primary care doc as far as the family is concerned, they would take their family member in to see their doctor to say, I think it's time that we may think about a palliative or some support or what do you suggest as far as that's concerned?
Well, when you start to see that decline in the various disease processes, uh, COPD, for example, you have
Mm-hmm.
somebody who's smoked cigarettes for many years and they're now
Mm-hmm.
respiratorily impaired. They can't walk into the office without having to stop and rest. They need the assistance of a rollator device. They need oxygen. Then you might be start to have that conversation, especially if they're continuing to smoke cigarettes. So obviously their disease process is not going to improve. If the patients are going back and forth to the hospital, you keep getting those notices from the insurance that your patient's in the hospital, or they're coming to you um, post a visit to the emergency department as they should to let you know that they did go and what was done for them. Those could be clues and triggers that their disease process is worsening
Mm-hmm.
and that they're needing more and more care.
Mm-hmm. Hmm. Do you find that when you educate families and you pull all this together that a lot of times the patients actually maybe they don't medically get better, but overall things just flow easier for those particular families and the patients, even in communication or even relating to each other? Or do you find that it's better?
Definitely found that it's better because that communication, that's the key. There might be a time that before that when you didn't talk about it. I ask patients on a daily basis about their family history. They don't know that their parents have high blood pressure. They don't know if they're taking medication. So that now opens that up because we don't sit around the dinner table anymore and talk about our day,
Mm-hmm.
talk about our health care. So we have to start that conversation. And also, what will happen is as we start to talk more and more about it, you get more comfortable and the grieving process can begin. Anticipatory grief. You realize that, okay, dad is getting older now, his
Mm-hmm.
health is declining, this time is coming sooner than later now. So you can start your grieving process and help to get through that for yourself as well. So, with that grief process in hospice, there's the bereavement manager. And hospice follows the patient, and this is all hospices, for 13 months past the death of the patient. And that's so you can get past all the first misses and the anniversary of the death. So, the first birthday that you're not there, the first Father's Day, Mother's Day, Valentine's Day, Christmas, Thanksgiving, whatever other holiday um, that you celebrate in your various cultures and beliefs. Get past all those dates. So that's where the bereavement stays with the family members, the survivors, to get through that grieving process.
Yeah,
So the early,
I did not know that. I did not know that hospice extended that to the family even after the
Yeah.
expiration of the patient. Did not know that.
this hospice is not just for the patient, it's for the
For
family
the
as well.
survivors,
So
yeah.
as you're
Hmm.
having that conversation and getting this in place, that's how you develop that tie, that bond,
Yeah.
that trust to say,
Oh,
no, we're going to be here for you as well as for your loved one.
interesting, interesting. There's not a question, but it's a statement that came through. Thank you so much for your response. It states, this is a great topic and is much needed in our communities because culturally we are afraid of end of life conversations. It says great topic, and not only in our culture do I think that we're afraid of end of life conversations. We don't talk about our number one. I want to separate medical problems from psychological problems.
Okay.
We don't talk about medical problems, number one, but we definitely, I think, in a big way, kind of excuse or not said about psychological problems. Nobody wants to say, well, you know, I'm crazy, or I'm, having difficulties with my memory, or I'm like, it's things in our culture that we kind of avoid those conversations. Um, do you, and I'm not sure what your practice is made of. Do you see more African Americans or Hispanics or Caucasians? But do you have a way of communicating such that those families can come together and really open up? I mean, have a technique that you can kind of share with us that, give this a try or give this a try because it's very difficult because and I may be overemphasizing this, but I don't think so. That our the black community is a difficult community to treat, to take care of, and any way we can get into that culture and open it up, I'm always looking for it. Can you give us some of the ways that you do it? Because I know 110% that when you're talking to somebody who at the end of life, there's a million things going on in their minds. 110% I can say that. So bestow some knowledge is what I'm saying. You know what I mean? Because it gets difficult, and it gets difficult for the family, the physicians, and the patient itself. So any tips that you can give us, I'm open to hear.
Omar, if I might make a comment, you know, and Dr. Blake can give me an opinion on this. I find though that even though at the outset, I'm trying to be very careful not to take away hope. But I find that the sooner you start having these conversations, the easier it becomes because it becomes a kind of like a phase, right? The initial encounter, you start a conversation, you try to see what is most important to that patient. Is it the children? Is it the fact that they're in school and they're working on a degree and they want to make sure they get to that milestone? And when things change, it's often easier to make the adjustment and up the conversation and start the next phase of a conversation, than leaving it until the situation starts to head in a downward direction.
Mhm, mhm. Yeah.
Now, I agree with you there, Dr. Anderson, and to answer your question, Dr. Bay, you finally got one that I can't just give you an outright answer to. This is probably something that we're all probably dealing with and have to use our own personalities. So I have found over the years that I try to be unassuming first and foremost, and try to find always some sort of connection with the patients so that I can communicate with them to break that ice, if you will. Lets them know that right now in this window of time, this 15 minutes that we have, it's all about you. I make a note to myself, and Dr. Court, maybe you can chime in on this as well, that since you're internal medicine, I'm family, we look at our patients similarly, and that I try to remember to ask about their kid. Oh, how's your son doing? He's in school now, right? And that shows the patient that, wow, he actually did hear what I said 4 months ago. Now, I make idiot notes to myself to remember that. They don't have to know that, though.
Right.
They think that in that point in time that they are that in tune, that I'm in that in tune with them, that they can be themselves with me. So I had one of my long-term patients just yesterday said that she needs to be off from work, just for her mental health. So it had been a long, busy Friday. And I said, hey, well, what if I was off today? I need to be off too. Letting her know that I understand that I need to be off myself. But she truthfully has been trying to seek mental health care. It's been difficult getting her a therapist to communicate with. So, but she felt comfortable to letting me know that. And I tried to lighten the mood with her to say that I appreciate, that you're going through, and went ahead and documented that she needed to have this time off from work. So it's just how we're talking with our patients, the voice that we're using. Do we put the pad down and actually look them in the eye and talk with them? So I have a scribe now to let them know that she's going to take some notes while you and I talk, so I can pay attention to you. So that make that person feel comfortable.
Right. Right.
Dr. Blake,
Go ahead, Dr. Court. Go ahead.
one of the things that I struggle with in terms of dealing with patients from the Caribbean, the following. We're always told, well, is the doctor killed them? I'm sure Omar and Patrick, they've have encountered that. It's an issue that I see all the time. How do you deal with that? Do you have that same situation down in Atlanta in dealing with other people?
You know something? I have never heard that from my Caribbean patients, but I can understand where that might be a thought. Now, with my Latino patients, I have encountered where they migrate to the United States. This might be the Caribbean patients as well. And this is America. This is the land of plenty. You're going to tell me that you can't cure my disease? You can't take care of me?
I know.
So
Right.
they look to us to have all the answers. So I can understand where that might be a thought. And now that just opens me up. Thank you, Dr. Court, to make certain that I make sure that my patients understand that I'm going to give you the knowledge that I've encountered. Said earlier about quoting some of the places maybe I'm getting this knowledge from. And if they want to look up Dr. Google later and challenge me on it, then by all means they can, and they'll see that I'm giving them truth. And that just hopefully now makes them more endearing to I'm giving them my all at this time when they need it.
Excellent. Excellent.
Right.
There, another question came up on about 5 wishes. Let's take care of it because we don't have that much time left. how do you introduce the aspect of five wishes to a loved one or even prepare it for yourself? It says, is there something you can read? Normally, we only deal with this uh, when we have, actually, when we have to. So, um, I don't know if you can see this, the question, Dr. Blake, but this
Hmm.
five wishes is something that is very important, I feel. And a lot of people don't know about it. Each and every hospital have the five wishes forms right there. A lot of primary care doctors do as well. But I know I come in contact with it because of the critical care and in the hospital. But can you answer answer this question about the five wishes?
Well, that's the great thing about Five Wishes. It's not something that's unique to any institution or facility. This is something you can actually go online and Google and look up Five Wishes, and you can see what those wishes are, and then develop what your answers are for them
Hmm.
and put them in place.
Hmm. Hmm.
So this is something that's a lot easier now than it used to be to try to get advanced directives, again, going through lawyers and putting down this documentation. So this just five quick things that are found to have been important at end of life. Now there are more decisions that might come into play as well, but these are the five quick medical things that need to be addressed.
Right.
Hmm.
And the key, what you just said there, you can go online, just go to Google and type up five wishes and it'll come up.
Yes.
Yeah, excellent, excellent. Patrick, go ahead.
Yeah, I provide subspecialty care, but a small fraction of the practice is to some extent primary care, oftentimes with a younger patient. But I do believe that sometimes, and society has changed a bit, but families need to continue to be families, right? We'll have dinner and we'll talk about sports and politics, but let's talk about us, right? We talk about our finances, we talk about the children's education, what we'll do for the grandchildren. But we ought to instill in our patients that an important conversation is what about us, right? What if, right? What would you want me to do? And it actually, we're here sitting saying, we should start a conversation with the patients early in the encounter, but really, the patients could make it actually easier on us if they actually start having conversations among themselves, right?
Mhm.
Because they know their situation and will understand it even better than we can, right? So I think we should encourage families to start having conversations, and they don't have to wait until they're elderly. You know, Catastrophic things happen. There are unwelcome events. Um, so families really should start having conversations. And then our role in all this is to say to them, well, just the way we make notes about the grandson who's in college and the kid who's in law school, how are you and your husband getting along? How is he doing, right? It's Breast Cancer Awareness Month, and I was at the cancer walk in the Oranges last weekend, and my conversation to folks is, you know, men get breast cancer too. So while us husbands, brothers, boyfriends or whoever is saying to our significant other, "Did you get your mammogram yet?" Do they know they should ask me, "Hey, did you check your breast this month?" Because men get it too, right? It's a
Yeah.
two-way conversation, and actually, families having a conversation, it occurs even earlier than we think we should have the conversation.
Hmm. Hmm. Excellent, excellent. Great topic,
Yes.
Patrick. Um, Dr. Blake, we only have a few minutes. We only have about 6 or 7 minutes left. I'd like for you to sum up for us some of the key things that we've talked about as far as palliative care, what you think is important for um, those listening, and hopefully future people who will listen to this podcast or our webinar. Um, I think this topic of palliative care and hospice care is so important for our communities. And I'd just like to see if you would sum up and give us some highlights that we should that we've covered, but you know what I mean. Maybe it just sparks in our mind that we can remember that the audience can remember because it's a 2 hour thing, and you know sometimes we said something in the beginning and they won't catch it. But go ahead and
Sure.
give us your summation as what you think is important.
Well, first, I'd like to take a quick moment to again thank Dr. Omar Bey for one extending this opportunity for me. He first came to me over a year ago, had some difficulties getting our times together. Approached me last month and gave me the date, September 13th, and I had to let him know that I was going to be kind of busy on that day
Just a
as I
little bit busy. Go
just a
ahead and
little
tell
busy as I got married on September 13th.
Hey,
them.
congratulations.
Thank you.
Congratulations, brother.
But he did not give up on me. He came back and offered me this opportunity for today. So thank you again for the chance to come on and discuss this very pertinent topic. It is also the time when I just said I spoke just this past week with bridging the gap between the medical and spiritual community. I'll be speaking later this week about heart disease and how it affects our culture and community at an earlier age and worse disease process. So, yes, palliative care, it is very important. It addresses the symptoms that we experience as we age, as we advance with a diagnosis that we have been given, unfortunately. And it helps to address our symptoms, depression, anxiety, agitation, that are going on in pain, very importantly, as this goes forward. That's palliative care. That's looking in on us, making sure we're getting our medications, making sure that they're getting the medications working to the appropriate effectiveness. Because patients can take medication every day, dutifully listening to their doctors, but it's not effective. And maybe they're too ashamed to say it's not effective, or they don't know how to tell the doctor it's not working. They don't tell the doctor they stop taking it because it's not working. So palliative care is checking in on that patient. And as the patient is indeed getting the care and treatment they need to the level that it's supposed to be helping, and it is not, then they transition to hospice care. All hospice care is palliative, we said earlier, but all palliative care is not hospice. So remember that, because hospice is end of life. That means that now we are watching the patient unfortunately experience their end of life as the body begins to shut down, to not receive the nourishment, nutrition that we're trying to provide. The medications are not healing the disease. We're keeping that person comfortable and getting the family member, the survivors, also ready for this transition and next phase of life, living without their loved one. So let's get our communities knowledgeable about palliative hospice care. And for those who are not on the medical side, you're more on the patient caregiving side, hear that the physicians are looking out for your best interests, that they're offering what's best for you. We are trying to overcome the many years that, yes, indeed, we were mistreated, misguided, misled, but that should not be the case now.
Yes, true. And I just want to add, as far as our spiritual component to this is so important as well. Um, I mean, there are various religions and those that, you know, are spiritual and don't follow a particular religion. You know, they believe in, you know, the man above, but they don't follow one particular religion. And all of this is good, but this is a component that has to be acknowledged, has to be brought in, has to be. I think that's the foundation that kind of holds us together as humans. You know, caring for one another, treating each other the way that we would want to be treated, and even as little children, taking them and giving them the understanding of that spiritual or that religious. It's all about understanding how to communicate and treat each other. And I think that's the most important thing. And if we can, you know, let all of these barriers go and open up and talk to each other, I think that that just makes all of this difficult situation much easier to tolerate, much easier to get through. And yeah,
Yeah,
Patrick,
I see.
you have
I
your
see
hand up.
two.
You
Yeah,
always
I
got
see.
your hand up. Go
Yeah,
ahead.
I
I'm
see
going to be
2 minutes.
quiet.
Look, I'm meeting Dr. Blake for the first time, and I'm in love with this brother because, as you know, we struggle with this, Omar. And it's
Yeah.
interesting, you know, we're fixing to go to Guyana in a couple of weeks to do this mission trip.
Yes.
And it's interesting how culture influences this conversation, right?
Mm-hmm.
One of the
Mm-hmm.
things I was fascinated by, Dr. Court, you know, I went to Guyana for the first couple of times. There's actually a TV channel that's devoted to obituaries,
Yeah.
right? Um, and you know, so thinking backwards, you know, I'm thinking, sure, a lot of these are younger people, and a lot of it may be trauma, but I am reasonably sure that many of this is these deaths are in the elderly, and these are folks in the community. And from a hospice perspective, we because everything that we do is so institutionalized, right? We tend to not see how important the community is, how
Mm-hmm.
important it is to engage the community in the whole hospice end of life conversation as well.
Mm-hmm.
Because when it comes to the survivors, it's the community who's actually going to uplift the survivors. When Mr. Jones died, Dr. Court and I move on,
That's right.
unfortunately. Yeah.
Mm-hmm. Mm-hmm. Yeah, and Patrick, I'm glad you brought up the Guyana Medical Mission that we're going on in 2 weeks, right, Dr. Court? How many
That's
weeks?
correct.
In 2 weeks, we'll be in Guyana
October.
doing our medical mission, our yearly medical mission, and I'm excited as usual.
Yeah.
And that is an experience within itself. I mean, there's so many people that we help, so many patients. Whew, thousands of patients come through this week, and it's a whole team. And our fearless leader is Dr. James Court, of course. And we appreciate everything that he does to pull all of this together. It's a monumental task, and every year I'm just awed how he can pull it all together. But we're excited about going to Guyana, and the whole team, Patrick and everybody, and Dr. Court will be down there seeing patients for all week, and it's an amazing, amazing experience. So, Doctor Blake, one day maybe you'll join us down there. Just an
We
Sure.
invitation.
Yeah.
we started with
Right.
two. We started with two young men, and we've been doing this for more than 20 years now. Unfortunately, Dr. Saunders passed away.
Yeah.
The mission has to continue.
Yes,
And,
yes.
Yeah,
I,
well, that speaks to the legacy, right? That, you know, when the founders move on, and he's not the only one. There are a few other brothers who and participants who are not here with us anymore. And it seemed like each year, even when other people drop out, the numbers seem to increase. So, you know,
Increase.
it's you know, to your credit, Dr. Court, great
Yes,
work.
yes, yes.
we
All
have
right.
so we have so many new members this time. Boy,
Mhm,
it's
Yeah.
really people
mhm.
just want to come and join and be participating in what we do.
Yeah, yeah.
Well,
And
well,
sort
keep me informed, and if time and availability permit, would enjoy joining you.
oh,
Question
we
about
would.
it's good. It's good.
Yeah,
Yeah.
It's good.
yeah, yeah. We'd love to have you. All right, Dr. Blake, thank you so much for coming on and doing this topic. And I've been wanting to do this topic for a long time, but I just haven't had anyone that had your experience. And when I saw you at the NMA make that, do that lecture, I was like, I gotta track this brother down. We gotta
Yeah.
get this and get this on the webinar. Oh my gosh. So thank you for taking the time. I know you're busy. I know you're a physician, and time is of the essence for all of us. But thank you for coming on and doing this topic, and we're gonna keep moving forward. And if there's anything that I can do to help you going forward, or just let me know, give me a call. You're one of the brothers now.
Well, all right. Well,
All
I'm going
right.
to
Appreciate
check and see. I know Vitas does have a program in New Jersey. I'm not sure what city, but I'm going
Mm-hmm.
to see if we're in your area and make sure we get our team members to you so we can
Mm-hmm.
get this area that you brought up. And I'm sorry, yard guys outside. We can go ahead and get these questions answered for you in your unique and specific area and get those patients treated.
All right. Thank you very
All right.
much. All righty. So well, let me make my closing statement here. Um, Basically, I would like to thank OBHealthy for allowing us to bring this webinar to you. Without them, we couldn't do this. So and this platform is their platform, and they open it up to us, and we so appreciate this. This program is every second Saturday, this webinar. All you have to do is come into OB Healthy, and please let everyone know that it's so easy to join and ask your medical question. Just come into OB Healthy, hit the doctor's tab, and hey, register, and you can type your medical question in, and we will answer it. It's all about caring and sharing. That's what it's about. In our neighborhood, it's about caring and sharing. All right, so tell others, tell your church members, tell family members, even tell your enemies. Let them know that we're here to answer their medical question. The most important thing that I can say before we stop is that please do not change any aspect of your medical care until you talk to your doctor. Only your doctor can truly take care of you from a medical perspective. If you missed any of our past webinars, all you have to do is go to OB Healthy and hit our YouTube sign. All of our past webinars come up. We have so many medical topics that are important for the African American community. All righty. So, hey, listen, until we see each other next time, hey, I'm going to say peace and just keep it together out there. We're here for you, and we'll see you next month. Dr. Blake, thank you very much. We'll be talking, brother.
Yes, thank you for the opportunity.
All
Yeah.
right. Peace, everyone.
All right.